Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. I'm Peter Johnston and I'm the Vice President at the College for Workforce and Corporate Engagement. We're going to be hearing about the most recent set of guidelines on the urinary collection system. That's the renal pelvis, the ureter, the urinary bladder and urethra. The authors will be clarifying some of the aspects of the guideline, helping you to implement it, and they'll also be providing some practical tips and clinical scenarios. They'll also be here to answer the questions that you pose after the presentation. I'm pleased to introduce to you today's speakers, who are also the authors. They are Dr. Ashish Chandra, who will be leading with the presentation start, then Professor Eva Comperat, who will be continuing the presentation, and Dr. Aiman Haider, who will also be here for the questions. Before we start the webinar, can I just remind you, please, that the presentation will last approximately 15 minutes, and then we'll have about 20 minutes for questions and answers afterwards. All the participants will be muted, and so if you want to ask a question, please do so using the Q&A function at the bottom of the bar on your screens. We would go on and address those questions as part of the response to what people are putting in. So without further ado, I'd like to ask Ash if you would please start with the presentation. Thank you very much. Over to you, Ash.
Thank you very much indeed, Professor Johnston, and good afternoon, everyone. And I would also like to take the opportunity to thank my co-authors and colleagues, Aiman and Eva, for their hard work in putting the guidelines together and also the slides for this presentation. So let me just minimize my screen. Here we go. Okay, so this is what we are going to talk about. But before we really get into the nitty-gritty of the guideline itself, just a reminder, particularly for our younger colleagues who are involved in doing the cut-up perhaps far more than some of the more senior ones are. Just a good reminder for just saying that a good cut-up is a selection of the most informative areas of the specimen in the smallest number of blocks required. So every block you should take, that you take should be justifiable. And it doesn't mean that you have to do a big cut-up in order to do a good cut-up. So more blocks do not necessarily equal a good cut-up. If your institution is biobanking specimens routinely, then these specimens will probably be sliced and they should be sampled within 20 minutes of their surgical removal. So you'd have to be located pretty close to theaters to enable this. And this is usually done, particularly in our setup, by an advanced practitioner BMS or a consultant BMS. And but we should also train up BMS and pathologists to be able to supervise these in the future. So the preparation for cut-up, of course, is pretty much the same as any other day. We're just drawing attention to the two main points here, which is, of course, the use of the voice recognition dictation system, but you could also use the RCPath proformas for entering your information onto. And then, of course, access to EPR on that system is really helpful because we encourage you to look up any previous medical details and histological and radiological details at the time of cut-up so that you have all the information you need for appropriate sampling. So let's move on to 2 or 3 specimen types that we'll probably be able to cover in this short space of time. So I'm starting with the nephrouretectomy specimens, and here really just the text slide to summarize what you do on the receipt. You bivalve the kidney, you could maybe selectively ink any areas of interest. Remember to take the distal margin, which is often a bladder cuff margin in these specimens where the entire ureter is removed, which could be anything between 50 to 20 centimeters in length. And then you could serially slice the ureter at 1 centimeter intervals. And if the tumor is situated within the ureter, note the extent of its local spread into the ureteric wall or beyond, and embed the entire length of the ureter that is involved by the tumor. And then just take representative sections from above and below the tumor segment. If the kidney looks uninvolved, apart from hydronephrosis, then you don't need to sample it extensively. On the other hand, if the tumor is located in the renal pelvis or in the calyces, then you should serially slice the tumor and the kidney and note the tumor size and spread and take samples which include the deepest point of invasion. So the guideline documents, of course, do not have any pictures. So we've tried to include some photographs of cut-up specimens here. And here you have an NU specimen with a guide wire in situ. So you can see it's reaching all the way up into the renal pelvis. And here you can see this firm white tumor, which is clearly invading into the renal parenchyma. So you could, of course, you would remove the stent, you would serially slice the ureter, which did not in this case contain any tumor, and the kidney could either then be sampled longitudinally or transversely. But the idea is really to look for the deepest points of invasion into the pelvic fat, perinephric fat, and into the renal parenchyma. And you would then actually have not a huge number of slides that you need to look at. You'd, of course, have the bladder cuff margin. You would have maybe the lower and mid and upper ureters sampled, and then you go into the renal pelvis close to the PUJ, and including some normal renal parenchyma, and then the tumor, including their deepest points of invasion. So not an unreasonable number of slides to examine. Of course, you should now be using TNM8 for some time now. This is one of the revisions in this particular guideline from the last time that this was written, when we were still using TNM7. So that is one of the changes to this document. And of course, you have to be able to answer all the points that are included in the staging system in your report. And if any lymph nodes are submitted, to also remember to offer a lymph node stage in the specimen. So your sample report in such a case actually could be quite brief and include all the important positive and negative findings, the grade of the tumor, presence of any CIS, and the depth of invasion for appropriate staging, mention of any lymphovascular invasion, and of course, the clearance of the distal margin and the circumferential margins. And the final stage could be summarized thus. And as you will see, this is stage PT3 because the tumor was clearly invading the renal parenchyma. And at this point, just in case PD-L1 immunostain is requested at the MDM, it's a good idea to identify the best block for ancillary tests. Let's move on to a cystoprostatectomy specimen. So here again, you ink the specimen either into anterior or posterior halves or right and left, depending on your preference. Shave off the urethral margin, which in the case of sample that includes the prostate would also be the apex of the prostate, but you do not need to cruciate it like you would do for a prostatic adenocarcinoma. You could just submit the urethral margin en face. And then you could either embed the prostate in large blocks, either all of it if it's a small one, or at least alternate slices, particularly remembering to include the one that is closest to the bladder neck, particularly if the tumor is located in the lower half of the bladder. The distal ureteric margins are now usually sent separately, so don't worry about struggling to find, the sort of retracted bits of the ureter, which are, stapled and clipped together and will have, shrunk back into the bladder wall, because it's more important to sample the separately sent distal ureteric segments. And then, of course, you sample the bladder. Just note if there are any obvious visible tumor nodules in the fat, because that immediately gives you the stage of the tumor as PT3B. If there is no obvious tumor, as is often the case with the post-neoadjuvant treated specimens, which are more than half of the ones that we receive, then you should really do a quick check of the imaging and any cystoscopic findings. So you can just do some targeted sampling of the cystectomy specimen. So here for the orientation is this is the prostate here at the lower end. So this is the anterior surface, and then on the lateral surface, you've got the peritoneal reflection over the bladder. So you could ink it either into left and right halves, which is quite helpful because it also helps you indicate the left and right halves of the prostate. And then you sever the prostate at the bladder neck, and then you cut open the bladder into either lateral right and left, or anterior and posterior. So here you'll see at the time of biobanking, this is a different specimen which was received fresh and has been opened into posterior and anterior halves. We'll discuss the relative benefits of this later. So this particular specimen was opened into right and left because of where the tumor was located. If it's on one of the lateral walls, it's probably easier to divide it into left and right halves. But in order to know this, where the tumor is, you should be familiar with the imaging and the TURBT specimen report. And then you just slice the prostate, lay out the posterior wall and the anterior wall of the bladder, and then you choose your points of interest, and these could either be submitted into mega blocks. I'm not suggesting that you embed the entire prostate and the entire bladder. At this point, you can just select the blocks that you need, at least alternate blocks of the prostate, and then just the targeted relevant blocks from the bladder, so that you could actually have a cystoprostatectomy specimen that neatly fits into one tray. Of course, the lymph nodes and the distal ureteric margins would be extra specimens. So here you've got the margins, you've got the prostate, and then you've got the areas of interest of the bladder. And don't worry if it's a really complex case, which includes the kidney and the ureter and the bladder. You just do it one step at a time. You gross the kidney first and the ureter and then the bladder, but in exactly the same steps as I've already described. And now it's over. Oh, sorry. So of course, again, to stage the tumor appropriately, you will be using the TNM8 staging, which I'm not going to read out to you. I'm sure you're already using this in your clinical practice. And again, to remember to stage the lymph nodes. Generally, you'll find around 15 lymph nodes in a pelvic dissection, and the surgeons really would like you to find as many as possible, but they kind of generally expect around 15. So this would be a kind of a short sample cystoprostatectomy report, which includes all of the key features that you need to include in your report. So it doesn't actually have to be a very long report. And then, of course, the final summary, which is very important. And again, identify the best block for ancillary tests. And for the last part of the presentation, I hand you over to Professor Comperat.
Thank you so much, Ash. This is really kind. So just very shortly, you don't only have men, sometimes you also have female, which is a pelvectomy. And so you have the uterus, you have the bladder, the vagina, and the ovaries. So of course you have to take a little bit everything to be sure that you do not miss anything. And especially here, I would like to underline on the left, it's still a cystoprostatectomy. And here you can see that the tumor probably invades the seminal vesicles. So this is really something which has, of course, to be really examined. And even if you're not really sure here on the grossing, at least you will be sure on the microscopy. And on the right, you have a female bladder once again. And you can see here this kind of where it's very close between the bladder and the vagina. You have to be really very, very careful. And this is really the part you have to take. And sometimes I take it even in the big whole mount sections to be sure to have everything. So if you have a pathology report, of course, you have to put in the histological type, the subtype, how many percentages of a subtype exist, whether it's a single or a multiple lesion, the size, if it is possible, the depth of invasion, especially also if there's an invasion to other organs, lymphovascular invasion, carcinoma in situ, of course, and then the margins, the urethra margin, but also the urethral margin, and peritoneal margin, because we know that people who have positive peritoneal margins really do less good than the others. Vagina, cervix, whether the tumor is very close, normally I mention at least if the tumor is really very close, or of course invading especially the vagina or the cervix. And then once again, to come back what Ash has already said about the lymph nodes, yes, we have to try to find lymph nodes. There sometimes are lymph nodes in the perivesical fat. So what I always do, I describe the size of the lymph nodes and whether they're normal or not. And when they have an invasion, I say how many percentage of the surface is part of this invasion, and whether yes or not there's a rupture of the capsule of the lymph node. And then, of course, give a PTNM stage, as you have already said. So just to make very, very clear, if you have one tumor in the bladder or in the urethra, then you have one stage. And be aware that bladder staging is not the same as the urethra staging. If you have one tumor and it grows into the urethra, so be aware that you really have a look whether this is the same tumor or whether it's not another tumor. But here, once again, one tumor, one stage, and of course you give the highest stage. And even if it's huge, you have to have a look where it comes from, because I told you already that different stages. So here, for example, on the left side, you have one tumor which is in the bladder and another one which is in the urethra. And here it's not really, they're not together, it's really two different tumors. So of course, there you have to give two different stages. And then T3 is pretty easy, it's microscopic or grossing. And T4 is depending very much how it grows. So if it grows really directly into the prostate, probably it's not as aggressive as it goes outside from the bladder and then into the prostate. These cases really have to be mentioned because we know that they have less good prognostic, and it's pretty complicated to make them survive for a longer time. I think this is all. And there have been questions in the chat I have already seen.
Yes, thank you very much, Eva. Thank you, Ash. There are a number of questions, and so I thought we'd start off with something that is relatively straightforward, and it's a question about the TNM classification, and I did see a thing from the college came round the other day suggesting that we move towards TNM 9 from the beginning of January next year. I'm assuming that we'll be able to translate the TNM 8 staging quite easily into TNM 9.
I think so.
Yeah, there's not really a problem there.
No, I think the only problem I have eternally with TNM is that it does not really mention the colon. And I mean, sometimes these tumors invade, of course, the colon or the gut. It's obviously T4, but it's never mentioned. So be aware it exists, unluckily, sometimes, yeah.
So that's just direct adhesion and straight through.
Yeah.
Which, of course, is not anatomically unreasonable because they sit close together, don't they?
Yeah, absolutely. Unluckily, yeah.
There's a couple of questions. Thanks very much for clearing that up. There's a couple of questions around about processing. So the first one is really about fixation. And how do we recommend we fix these specimens, particularly for cystectomies? Because they're big specimens, and do you recommend cutting them first or infusing them, or how would you go about that, and what would you use?
Yes, thank you. I'm happy to make a start, and then we can have a discussion around it. So we encourage our urologists to inflate the bladder with formalin, about 150 to 200 ml of formalin, which is available in theaters anyway, through a Foley's catheter, and to fill the bladder up with formalin before they send it to the laboratory. This, of course, would be true for the specimens that are not being biobanked, which of course we have to receive fresh, unfixed, and within 20 minutes to sample them. But for the ones that are patients who have not been consented for biobanking, then that is what we recommend. And this really just allows the fixation of the tumor to start as early as possible and to give us good morphology, which is so important for grading of urothelial tumors. So we really encourage the early fixation and exposure to formalin. And this particularly gets around the issue of receiving a specimen on, a Monday morning of a cystectomy that was done on, say, maybe Friday afternoon. And, the tumor's been autolyzing away all weekend. And by the time you open it on Monday, it's already mush. And it's true for testicular tumors as well. We really recommend early fixation and good morphology for these two tumor types in particular. Of course, it's true for all tumor types, but that is our recommendation, to inflate the bladder with formalin in theatres using a Foley's.
Great, thank you very much. That's very sound. Just following on from that, there's a question about inking. And, do we ink the whole thing? Because that takes a lot of ink, takes time, is messy. Whereas, do we really just need to ink the bits that matter? How do we determine which bits matter, I guess, is the question then.
Yeah, well, I can, as I showed in my slides, we don't have a massive love of inking, apart from the prostate, which you do need to ink into left and right halves. And then as for the rest of the bladder, rather than smearing it in different colored ink, which isn't really going to tell you very much, the important thing would be perhaps to just selectively ink the areas of interest. So although in the images that I showed you, there was ink that was smeared over the entire surface, but it's not something that we do for all of our cases, particularly if there is tumor in the perivesical fat, for instance, and we want to be sure that the perivesical circumferential fat margin is clear, then you literally just need to dab a small area of tumor that is shining through the peritoneum, or that is bulging on the surface. Also, you have to bear in mind that if you smear the entire organ in ink, and you're not the person cutting it up the next day, and it's your, a different colleague who's going to cut up, all of that information is lost. It's all, covered up by ink, and then you don't know where the point of interests were. So I think inking should be done at the time of cut up by the person who's actually going to do the sampling.
That's very helpful. There is also a question about plane of section of cutting, and again, you did mention, Ash, when you were talking about it, that you can go either in a sagittal or a coronal plane, just whatever suits best, because of the orientation of the tumor. But it does assume that you know where the tumor is, and if you're not aware of that, I guess you can feel it, but
yeah, I'm happy to answer, and sort of defend my position on it first, and then we can to the other panelists. So my preference really is to open the bladder specimen after the prostate has been removed, of course, into anterior and posterior halves. And what this allows you to do and get into the habit of doing, and this was demonstrated very nicely by Ava's case of the anterior exenteration specimen from, say, a female pelvis, where you want to demonstrate the continuity of the tumor, particularly if it's located on the posterior wall, and its relationship to the more posterior organs. So whether it is going through the wall of the bladder and into the parametrium, or into, close to the vaginal cuff, or into the paracervical tissues, is really very useful. And that way, if you've left the uterus and cervix attached sort of back to back with the posterior surface of the bladder, then you can get some continuous sections as mega blocks, or even as small sections, that will help you stage the tumor most easily. So my preference is to open the bladder into anterior and posterior halves, and then just lay out the slices as I demonstrated, of the posterior wall and the anterior wall. But that's not to say that to divide them into right and left halves is wrong. And I noticed that the same is true for my colleagues who do gynae histopathology. Some of them have a preference for opening a uterus into right and left halves, whereas others tend to open it into anterior and posterior halves. So I think there's no wrong or right answer. There is a method, there's preference, but my reason for preference is, as I stated. Thank you.
Yeah. Thank you. I mean, the real important bit is taking the right pieces of tissue for processing is the thing, and however you do that. Good, thank you. There's a question about blocking of ureters. Oh, but before we go to ureters, there is a question about how do you maintain the shape of the bladder once it's open, and again, um, it's a long time since I did this, but our preference was always just to leave it because if you put stuff into it, then you might damage the mucosa, and so it was better not to. But what do you think about that?
Yeah, I couldn't agree more. I always make a big interdiction that people put in paper and before the fixation. It's really the worst thing you can do with the urothelium. You should never ever do that.
Okay,
But
thank
I
you.
think you should also not have any fear if you have a sample which is not correctly fixed, then you fix it in another 24 hours. I mean, globally, people know what is going on, so 24 hours less or more does not really change the treatment plan.
I agree with Eva that fixing for an adequate amount of time always helps, and the specimen is out. So a day's delay is probably going to help the specimen better fixed with better morphology on what you get on the slides and not hampering it with tissue. Again, washing even the container it's come in, blood can hamper fixation sometimes. So, and replacing the formalin nicely once it's with you in the lab from theaters.
Very good. I'm old enough to remember the times when I was training in pathology as a registrar, 30 years ago, I dare say, that we used to sort of open the bladder and onto a cork and then pin it down along the edges. But those were the days when you used to see cystectomy specimens for low-grade, non-invasive tumors, and it used to be quite a sort of a spectacular specimen to sort of pin out on a cork board. But we don't do that. I don't think preserving the shape of the bladder is necessarily a useful thing to do. I think it is its relationship to the adjacent organs and to be able to get good sections and planes of section that gives you the maximum information about the depth of invasion and involvement of adjacent organs.
Okay, that's great. Thank you. There's a number of questions about further investigations, and I'll come to them in a little minute. But I just want to finish off the grossing questions first. So the ureter is always a tricky piece of structure to look at because it's difficult sometimes to know just where the tumor is and how invasive it is, particularly if you've done transverse sections. So there's a question really about how do you best estimate where the deepest invasion is, and alternatively, should you block the whole thing?
No, I think it's really much. No, but no, I mean, I agree. It's sometimes extremely tricky because very often you have a kind of fibrous socle and you do not really know very well where's really the most invasive part of the tumor. So there, I really would say, well, you have to take maybe 4 or 5 blocks, but this doesn't mean you have to block everything.
No, sure. I mean, I'm assuming that we're talking about, the entire nephrouretectomy specimen, but usually you will know because these cases will have been through the MDM and you have access to the imaging. There will be enough information there to tell you that the tumor is present in the distal 3 centimeters of the ureter. So you actually going to cut up knowing where the tumor is. Also, you just feel the entire length of the ureter to see where the firm thickened bits are. And usually above the level of the tumor, you will find that there's a hydroureter and maybe hydronephrosis. So the part that is proximal to the tumor will be thin-walled and dilated, whereas the area that is tumor will be thickened. And you could just measure that length. And, if it's just 3 or 4 centimeters, you can easily block that in, of only a few blocks. And then you just need a couple of sections from the more proximal, thin-walled, dilated ureter, just looking for any adjacent sort of CIS flat lesions. And of course, you're also going to take some blocks from the renal pelvis and calyces. So I wouldn't worry too much about submitting the entire length of the ureter. I think pragmatism would definitely be welcome here.
I think I will also reiterate what both Ash and Eva has just said. Going into a macroscopic cut-up room is like a ward round for us in pathology. And I always stress the importance of looking up all the clinical details, the imaging of the patient, the previous MDT discussions, because then you know what can be smart sampling for the specimen that you've received. And a good macroscopic examination with all these details in mind always helps you save on those blocks.
Yeah, I think it's a very useful point. You know, the whole purpose of having skilled people dissecting specimens is to sample the specimen appropriately. Because if we just sample it all the time, we don't really need any of us. You can put it all in a bacon slicer and somebody can just put it all in a block after that. And that's really not the purpose of the sampling exercise. So there's a couple of other questions that will just go down through the urinary tract, and one's asking about prostate. And again, I think you kind of mentioned this to some extent, but how much prostate? You said every alternate block, every alternate slice perhaps as a first in, but how do you choose how many, and when would you choose more than that?
So
Ah,
as I made that statement, I should, I suppose, go first, and then I'm very much open to controversy and criticism. So, I mean, the idea of sampling the prostate in a cystoprostatectomy specimen is not to hunt for incidental prostate cancer. So that is the first thing to say, that the reason why we're sampling the prostate is not to look for prostate cancer. It is to see whether there is involvement of the prostate by the bladder cancer. And that, as Eva demonstrated, you could have involvement of the prostate in two ways. One is contiguous, which is that the tumor is spreading along the urethra. So it is coming from the bladder neck and then spreading into the urethra and then becoming a urethral tumor. And that is the reason why you want to take blocks, always include the one that is closest to the bladder neck. And then the second pattern of spread is when it is actually coming out of the bladder wall. So it's coming onto the surface and then invading the prostate through its capsule. And that is true PT4 disease because it's involving the prostate like an adjacent organ, like it would involve, say, the rectum, for instance, in that location. So that is the purpose of sampling the prostate. So the bits that are closest to the bladder neck are the most important to sample. Of course, there are alternative ways of sampling where you could literally remove only the urethra, the entire length of the prostatic urethra longitudinally, and then submit those as either longitudinal or transverse sections so that you're then only really assessing the prostatic urethra for CIS or contiguous papillary tumor. Over to you, Eva.
No, I mean, it's very useful what you say, and I think I totally agree with you. So there's nothing more to add because you're very, very clear.
So we just, thank you. We just continue downwards, and you've been talking about bladder neck quite a bit there. But someone's asking about what do we do where if we take the transverse section and then we notice that there's been retraction of the urethral mucosa inside that block or beyond that block. Should we be taking cruciates? What's your opinion on what the benefits of the cruciate prostate versus the shave are?
Well, I mean, the reason why we cruciate the apical slice of the prostate is to look for apical margin involvement by prostatic carcinoma, which, as I said, should not be a consideration here. If the urethra has retracted, and that is often the case with, say, an anterior exenteration specimen from a female patient, because the urethra is shorter, and so it may retract, then, of course, what you're doing is you're sampling a little bit further up into the bladder neck and making an educated assessment as to whether the urethral margin that has been submitted, usually the entire urethra would have been submitted in the case of an anterior exenteration specimen. Where the urethral margin is really important is in the case of men, because the penile urethra is still in situ. And so if there is tumor or CIS reaching the distal margin of the prostatic apical urethra, it means that the patient may have involvement of the penile urethra and may subsequently need a completion urethrectomy to remove any CIS there. So if you just bear that in mind, you know, what is the rationale for getting a distal urethral margin? It's probably more important in men where the penile urethra has been left behind. And then you just try and get the distalmost part of the urethra, whether it is retracted back into the bladder neck in the case of a female bladder, or it's retracted into the prostate in the case of a male patient.
Yeah. Okay, thank you very much. I think we move on to staging questions now. We've quite a few questions about staging. So again, I'll start at the top and work down. So there's a question about the fact that in invasion of the kidney, it's quite often a pushing margin. And how do you estimate how best to stage that depending on the pattern of that infiltration?
Eva, do you want to take all the difficult questions?
Thank you so much. It's really nice. I'm not a native speaker and I can all do the weird ones.
Perfect.
No, I mean, the pushing borders are, of course, a problem, and there will always be a problem for everybody, as it's not really very easy. So as long as it's really, you know, this kind of horrible thing growing into, it's easy. But the pushing borders are really a problem, especially when you go to the muscle, because it can push forward and destroy the muscle. So as soon as you really have a kind of interruption, I would say, of any structure, well, I would call this probably invasive. But otherwise, it's, of course, very, very complicated. What helps me a lot in my experience is I cut a little bit deeper. You do some 3, 4, 5 deeper cuts, and sometimes you really can sort it out then. And if it's still the same, well, it's still the same, and that's really bad luck. And then you send it to Ash, and he will answer.
That's a cop-out.
But these are those cases that do need team consensus, teamwork, correlation with imaging, and going back to the patient as a whole.
Absolutely.
I mean, I think, again, there's a sort of observation from stage left. It is an opinion that we're giving. It's an interpretation of what's in front of us. And so there is always a call for the need to reflect on our own capability of doing these things and do the best we can. And as long as we're doing that, within reason and with reference to what the information out there is, there are times we can do no better than that, I suspect.
Absolutely. I mean, in the case of upper tract tumors, actually, this is not a kind of a clinically particularly significant factor because the entire kidney has been removed. So whether you're staging a collecting duct tumor as non-invasive or PT1 or PT2, the entire kidney has already been removed. So there's no more structures to go back and remove. Of course, the stage will influence the prognosis and the risk of metastasis. So it is still important, but not in terms of the completeness of resection.
Yeah, good. So in the bladder then, there's a question about bladder diverticula and how do we go around dealing with bladder diverticula and infiltration of tumours around and within these? How does that affect your staging?
It's always horrible. Now, I mean, there are two things. Excuse me, Ash, but if you want to say something. So there are two things. There are the acquired diverticula and those who are congenital. So this is something which is very important because in the congenital, you never ever have muscle. In the acquired, you can have muscle, but nevertheless, I would not go to PT2. I would really remain very descriptive. Sometimes they say there's still some muscle and the tumor goes beyond or still above the muscle, but I will not go into PT2 issues. I don't know about your opinion because it's a very difficult topic.
Same as with respect to staging. If it's infiltrative, it's PT1. Never comment upon PT2. And we've had a few going into fat where we've called it PT3. Yeah. But never comment upon PT2 because muscle is not meant to be there. And with respect to grossing it, I tend to do serial slices perpendicular to the lumen of that partial specimen that's been received and embedding what's again relevant with deepest points of invasions and where the macroscopic tumor is.
Mm-hmm. Yeah, absolutely. I mean, the amount of muscle or muscularis propria and diverticula is very variable to almost absent. And the urologists know that, when they're dealing with a diverticular tumor, if it's looking in the least bit suspicious, chances are that it is PT3 disease already, even though, it may not look like it on imaging. So they go into these tumors full well expecting them to be higher stage pathologically than they appear to be radiologically.
Now, I think the orificium is really very important so that you really have the good orifice and say, well, there's nothing or there's still some carcinoma inside or whatever you can find. I think this is really much more important probably.
Absolutely, because the reason why they're doing a diverticulectomy is that they think that they can preserve the bladder for as long as possible.
Yeah.
So if the mouth of the diverticulum at its point and circumference of attachment to the bladder is free of CIS, then at least you can justify having done a diverticulectomy and conserving the bladder, although of course it remains at risk for developing CIS.
Mhm.
Thank you. I do want to ask some questions about CIS, but we'll come back to that. Just briefly, because we're going to run out of time, and I'm going to apologise now because we're not going to be able to cover all the questions that are in there, but we will endeavour to come back to you with the answers. I think one of the things that people are asking is about the use of immunocytochemistry. So first of all, what would be the best block for using for example, for PDL1 testing? Should you use the deepest invasion or the most inflamed part or a piece that's clear or where? And then the second question, which somebody can be thinking about just now, is about the value and the interpretation of MMR-IHC in bladder cancers. So if you could take the first one first.
Eva, I think this is
That's once again a lousy question. I'm sorry.
about PDL1 and what.
PDL1 is always lousy anyway. Yeah. I mean, the problem is, of course, we know we have a very heterogeneous expression, and sometimes you're lucky and you have the good block and it's positive and everything is fine. It's not always the most inflammatory block. Be very careful with necrosis. You should never ever give an interpretation on necrosis because sometimes you can have PDL1 expression in necrosis. Any immunohistochemistry can show up in necrosis. And then I would say if it's really negative, well, you have to ask yourself, do you want to do a second block maybe? Do you want to try a second block? I know very many people don't do that. And personally, I don't do it either. But maybe we're wrong. And this is something which is totally unresolved.
Yeah. So yeah, I mean, basically the idea is to go for the worst bit of the tumor, but where at least the morphology is still well preserved so that the PDL1 scoring can be done. And it's it's got a good tumor infiltrating lymphocytic infiltrate in the block. Of course, it also depends on which clone you're going to use, and the choice of the clone that you're going to use of PDL1 will depend on the drug that is being used to treat it. So if it is nivolumab, you need to know that because you'd be using a different clone to say Pembro is being used. As for the MSI testing in Lynch syndrome patients, again, that is something that we wait to be asked to do at the MDM by the oncologist. So that's something that you don't sort of reflexly do. You wouldn't do PDL1 reflexly either. All of these have to come as a request at the MDM from the oncologist. So both of those tests, I would say, should be done only at the request of the oncologist.
Okay.
Yeah, and just two things, excuse me, about MSI testing. The first thing is that we do not have very good data because most of the MSI testing was done on endometrium and on colon carcinoma and not on upper urinary tract. The second thing is if you have an old patient who is 85 and he has an upper urinary tract, well, he will be not Lynch quitty probably because Lynch patients are much younger and they have a little bit different aspects in the tumors.
Okay.
Another thing we find helpful in our everyday reporting, because these come back retrospectively as clinical requests in resection specimens, is noting the tumor block for reference for molecular testing, which contains good percentage of viable tumor.
I said I was going to ask you about carcinoma in situ, and I'm conscious we're actually at time. So if we can very quickly think about the significance of CIS and how we deal with it, particularly given it can be patchy, and how you interpret that and what you do with it. So a short answer and then we'll have to wind up, I'm afraid.
So don't do frozen sections on ureteric margins to look for CIS. It's a waste of time. Simply for that reason, because there are skip lesions. It's multifocal disease. And if there is CIS in the bladder, chances are there's probably CIS already somewhere in the urothelium elsewhere. So these patients will just have to be followed up in the usual way, radiologically by interval CT scans to pick up any real visible lesions. You can, of course, follow them up with cytology as well, depending on what type of operation is done for them to remove the bladder.
Okay. Thank you very much. Well, I'm sorry, everybody, but that's all we've time for today. I would just like you to remember that the recording of today's webinar, including the questions and answers, will be available soon on the college website. And it's a resource there for fellows and members to support with the implementation of the guidelines. So if any of your colleagues weren't able to watch it today, please let them know and they can watch it on the website when it becomes available. I also need to tell you that the clinical effectiveness team, the professional guidelines team, will be sending around a short feedback survey, and we'd love to hear what you think of today's webinar. So it just remains for me to say thank you to all the authors who've spent a lot of time putting this guideline together. It's vastly appreciated by all of us out here who use them, and also for sharing the time to give us their thoughts about how best to implement these guidelines. In the meantime, we'll be continuing the webinar program in the new year, and you can find out more about that and what's coming on again in the webinar page in the college website. So all that remains for me to do is to wish you the compliments of the season and all the very best for the very quickly coming on 2026. Thank you all and goodbye.